Hello everyone, we're going live. Here they come. Here comes the posse. Everybody's joining. Hello everybody. Welcome to Ask the Aesthetic Mentor. Lulu, this is early for you. Welcome. Good to see you. I feel like I haven't talked to you in a while. Be nice to catch up one of these days. Tracy's one of the usual posse members, so she's always on board. Good to see you, Tracy. Cosmetic nurse. You're an aesthetic nurse also, really. Cosmetic. I like the word aesthetic because it sort of takes it to a higher level than cosmetic, I think. That's just my own personal opinion. But you got to brand whatever you got, right? So, hey, Lulu. Lulu's one of our student advisors, and when people call in and ask about, courses and what to do and what's the path to success, Lulu she's like a guidance counselor for aesthetic mentors, so she helps people figure out how to get where they want to go and helps them maneuver and gets them set up for classes. And she works with Sigourney, and together they're a knockout team. I think so, Tracy. I mean, I think, hey, MK is the... I'm just going to call you the producer, and there's Speraza, who's always with us, one of the usual posse members, and MK Horrigan, his kind of comes up with the ideas for the lives, and he's doing a good job with that. So thank you, MK. Getting some of the usual customers involved. So today, MK suggested we talk about touch-ups and some business issues related to touch-ups and what causes touch-ups and how to avoid them and kind of that whole thing, whether you should charge, not charge, and I think we'll get into that. But just kind of two things at the top that I wanted to talk about. Hello, Teresa Vanderboom. Vanderboom, I love the boom at the end of that. Hey, JKR Medical Leasing Company senior executive has just joined. She's in the house. I just want to talk about a couple of things. I did learn something today, and JKR may get a kick out of this. I learned something from a patient today. I learn a lot from patients, and I think if you listen long enough, you will. And if you listen to what people are saying, you can learn a lot from your patients. And I have a patient that's a long-term patient, and JKR will know who I'm talking about, who is in her 70s and has sort of an elongated upper lip. As we get older, our lips get longer this way and kind of wider this way and kind of get flatter, And over the years, she's had a lot of treatments, starting, more than 20, 30 years ago. And her lips were, a bit of a problem over time. So, I think what happens with lips over time is they end up staying big. Once you get to a certain point, they don't deflate anymore. You get that collagen synthesis going. You get some permanent deposition of the protein, and it just sort of stays big. So now she's presenting with this situation where she has a very elongated, upper lip, and she's got a reasonable upper lip in terms of the Vermilion show, and she was scheduled for a lip lift, where we excised skin from underneath the nostril base, and in effect we're kind of doing this. We're kind of shortening this distance by cutting out skin, so we're kind of everting the lip a little bit, so it looks more youthful. And as we get older, that distance obviously increases. So she's a very bright person, and she's very intuitive, and she's always brings in photos of herself. So she brought in like all these photos of herself from when she was younger, and she was showing me that she never really had a big lip, and that this distance was shorter. But she was worried about the distance out here. She's like, well, if you shorten this distance, you aren't doing anything for the distance out here. And she was talking about the distance from her upper lip to her nasolabial fold, and she couldn't quite understand how it would look. She said, I'm just going to look different if you do the lip lift. And I said, well, yeah. I started looking at the photographs, and she just was really concerned that she was going to actually have too big an upper lip. And I sort of stepped back, and I said, I actually totally agree with you. If we do a lip lift, because what happened over time is she has a permanent enlargement of her upper lip. It's almost the same size as her lower lip, and she's 72 or 74 years old, so she doesn't want to look done. She doesn't want to look unusual or abnormal. She just wants to look good for her age. So I said, you're actually right. Hey, Joyce, good to see you. I said, you're actually right. If you're looking at somebody, when you look at someone, you just kind of look at their face. But if you're looking, and every time you look, your eye stops at one point, like their lip or their nose or their eyebrows or something, your brain is telling you that there's something wrong with this picture because it keeps stopping. It keeps being stopped by something that's abnormal. And, I said, I think that would happen to you if I just did your lip. And Brittany, I'm talking about a patient that taught me something today about lips. That if I did that to you, I think it would distort your lip. And you never had much of a lip. When she smiled, her lips went flat. But this was when she was very young, and that's just who she was. And so she said, I don't want, in my age group, people are very focused on people who are doing things. And if it looks unnatural, they talk about it. So she sort of said, I'm just concerned that I'm going to look abnormal. And even though this distance is going to be smaller, my lip's going to be too big, and this distance isn't going to change. And I said, I 100% agree with you. You're absolutely right. We should not do the lip lift. Let's cancel the lip lift. And we ended up doing a little wide ace down here for a particular reason. But we ended up kind of working around the outside of the lip to kind of raise the lateral portion of the lip, and to enhance a little bit of the lateral of the red show laterally, because again, she was concerned about the distance from her nasolabial fold to her upper lip, and no one's ever sort of talked about it that way before, but this patient sort of made me realize that she was right. So the moral of the story is that just listen to your patients, and what I should have done was I should have asked her to bring in photographs of herself, because I think after you do this stuff for a while, you tend to just kind of go a little bit on an automatic pilot, but we shouldn't do that. We should evaluate each person like it's the first time we've ever done this. And if we look at the photographs of this patient from before, you'll see that she never had much of an upper lip. In fact, her upper lip is bigger now at 72 than when she was 40. So that's weird, right? So when people look at her now that knew her from before, automatically they're kind of stopping at her lip, because that's not the lip they remembered. If I were to do a lip lift and shorten it even more, I'm making it worse. I am making her look kind of done. I am making her look kind of funny, and that's not what I should be doing or any of us should be doing. So thank you, patient, for saving me from making that situation worse. We're not technicians. We're not mechanics. We have to be thoughtful and artistic, and we have to look at photographs of people, because it's not who I want them to be. It's who they are, who they want to maintain being. And everyone's now focused on looking funny, right? Particularly older generations. No disrespect intended, just being factual. So that was an important moment for me. So the point, again, is just really be better with your assessment of the patient and look at their older photographs and get inside their head a little bit and see what they want, what they need, because no one wants to have something that looks funny and everyone keeps asking them about it. So enough said. Second point, we sometimes look at other practices, as we have a sort of a consulting arm of the practice, and we look at other practices. And one of the practices we were asked to look at was having this really high rate of touch-ups, right? So, what is a touch-up? What does it mean? Do you charge for it? These are questions that Mary Kate has asked me to bring forward, because they're real, and when you're starting out, it's hard to figure this stuff out. So we, did a kind of a chart audit. Well, let me see what kind of problems you're having, and let me see what you're doing, where you're injecting, how many units, etc. And we found out that the vast majority of patients who were coming in for touch-ups were getting underdosed, and were getting injected in areas where there really wasn't any muscle or frontalis or, corrugator activity. And you're probably not surprised, because you're probably all thinking, well, Russo said a million times that dose equals duration. That's his E equals MC squared, equation, because that's all he talks about. So yeah, if you're in a practice where you're constantly underdosing patients, you are going to be doing touch-ups, if you want to call it that. but you're going to be redosing them to get the proper effect and the proper duration. So, you're not really doing any good. In fact, you're probably causing yourself to lose patients if you're treating them so conservatively that they're either not getting complete relaxation of the muscle, or their dose isn't lasting 3 to 4 months, right? And that's a problem. That's a real problem for patients. And they're going to just think you're not a very good injector. And, if you think about it, the on-label dosing for neurotoxin, like for example, Botox, dose adjustment sounds better than... Yeah, let me give you the dose adjustment that you really need. That works for the first 2 or 3 times until you get the dose right. But if you find yourself doing additional dosing on a single patient, the next time you do it, just do the increased dose, right? But if you think about the on-label, the FDA-approved on-label dosing, let's say for Botox, the forehead, 20 units. The glabella, 20 units. The crow's feet, 24 units, 12 on each side. Right? So 64 units for those 3 areas. That's the on-label dosing. That's the dosing that they use to calculate duration. That's the dosing that they use to get FDA approval. So most people, Allergan comes into some of the practices that they've done it for us, and they look at your average dose of neurotoxin per area, and it's always under that. It's always under 20, 24. And they look at retention as well. It's like, how often are your patients coming back? So when you look at that, saying, why is everybody underdosing? And I think when you're starting out, that's probably desirable. It's probably reasonable to be careful. Now I say, how about you just listen to me, then see you back in 3 months instead of getting touch up. Kate, the NP, has a way of just cutting right to the chase. Just sit down, shut up, and listen to me. Let me inject what you need, and don't worry about it. See you in 3 months. That's cool. I like that. But not everyone has that strong approach that you have, Kate. But I do appreciate that. And if it works for you, I would do it. Because if I'm a patient, I'd rather have the full dose and come back, at 3 to 4 months, than to be coming back in 6 weeks and saying, hey, this didn't work, or to come back in 3 weeks or 4 weeks and say, hey, I'm not fully paralyzed. I used the P word, sorry, or relaxed. But when you're first starting out, I think it's actually reasonable and actually desirable to do a, hey, Jersey girl, it's actually reasonable to do a conservative dose. Because the last thing you want to do when you're starting out is to create a ptosis, or an eyebrow or an eyelid droop, to get an asymmetry, to get a complication that, makes the patient really question your ability. And everyone kind of knows when you're starting out. I mean, you haven't been around that long. So just be cautious. But the thing is, if you're going to do that, you have to explain it to the patient. For example, saying, hey, I haven't treated you. I did this to the patient today. If you, I haven't treated you before. I don't know, what your tolerance is going to be for neurotoxin, how sensitive you're going to be, or anything like that. So I'm going to give you kind of a middle of the road dose. It may be perfect. It may be too little. Maybe a little too much. I don't know, but I think it's going to be safe. And let's see you back in 2 weeks, and then we can really figure out what that dose did for you. And when you see them in 2 weeks, you might say, yeah, it's a perfect dose, and we'll do that every time. Or you might be like, I probably should have given you more, so let's do that now and get that over with. So next time we know we'll give you, the additional units. Or you might be like, I think that's a little heavy for you. I think you're probably very sensitive to neurotoxin, so we're going to dial back the dose a little bit. And these are all reasonable things. But if that keeps happening, right, if your patients keep coming back with inadequate dosing, remember, dose equals duration, then you are not thinking this through clearly, right? So when we looked at this audit, when we did this audit of this practice, we found that the patients were, continuously being underdosed. And they didn't really know exactly where to inject it. They were injecting it laterally where there's no muscle. They were injecting it in these areas where there wasn't any motion. They didn't really understand the location of the frontalis primarily. So that's just being lazy. That's just not understanding anatomy, not going to seek out the actual information you need to know to become better. Always try to become better. So having said that, right, let's figure out what a touch-up is. what is a touch-up? Do you charge for it? How much do you charge for it? What do you say to the patient? Is it in your consent forms? All of these kinds of things. This is what MK wants me to talk about tonight, so that's what we'll do. So I think the first thing is, try to be on label. Try to give a full dose. Try to, get to the point where you are getting close to the on label dosing indication. Of course, we always have those patients who don't need as much, and sometimes we have patients who need more than that, but that's our own individual clinical decision. But for most patients, we're probably underdosing them. If you look at the numbers nationally, we're definitely underdosing them. And if you look at the retention rate of most patients, if you see a Botox patient for the first time, the likelihood of them becoming a permanent part of your practice goes down significantly if you don't see them within the next 4 months. If you see them the second time within that time period, the chance of them staying with you is very high. I mean, assuming you're a reasonably good injector. So it's important for those first couple of encounters with the patient to be good ones, because they can be your patients for life. And don't forget, a Botox patient for me is like a marketing play. It's like a loss leader. You make money in Botox, but it's not a lot of money. You do make a lot more margin on fillers, and then if you convert them over to energy-based treatments, if you have someone doing other things, or if you do surgery or other things, you can make more. But the idea is that this is a recurring, it's like an annuity, it's a recurring revenue stream. But believe it or not, like the average number of visits a Botox patient makes to a provider each year is like 1.2. I mean, really low. Our retention rate was 2.5 or something, which was really well above the industry standard, not even 3 times a year. So our average was 2.5, and they were like, oh my God, you guys are great. I didn't think that was great, but apparently it is relative to all of our other competitors in the area, regionally and locally and nationally. So that's why they started talking about, instead of discounting your neurotoxin, say, okay, if you come in within the next 3 months for your neurotoxin treatment, instead of charging you $17 or $18 a unit or whatever you charge, we're going to charge you $2 less. So let's say you're charging $15. So if you come in, like today's June, if you come in before September 14th, you will pay, $13 a unit instead of $15. That is a real incentive to the patients, because that extra visit is going to keep them relaxed. It's going to help the muscles atrophy. It's going to create better results. You're going to get better outcomes. You're going to get longer duration. It's going to be a better overall treatment for the patient, and it's going to be better for you because you're going to see the patient more often. It's going to be a better revenue stream for you, and you want to do the right thing for the patients, right? So we started explaining to these injectors, that they needed to do more neurotoxin, higher dosing, and they were reluctant. They're like, well, I'm afraid to get it. Have you ever had a ptosis? No, but I'm really afraid. How do you get a ptosis? Do you know the mechanism? Do you know the anatomy? I think if you put too much neurotoxin where? Too close to the eyebrow or the what happened? What are you doing? Like what's causing it to happen? It's getting into the eye they don't know the muscles, they don't know the anatomy, they don't know what they're talking about. So why are you injecting these neurotoxins? Why are you doing this to these patients? And you're so afraid of doing something wrong because you don't know what the right thing is to do, that you're just constantly underdosing. So it was kind of a revelation. You think this is a pretty unusual thing? Do you think it's pretty unusual that patients are being underdosed, or that providers aren't really cognizant of the anatomy? It's far more common than I even care to think about. It's really kind of horrible to watch some of these providers who have even been out there for a while, and they just don't seem to really get it. So kudos to you guys for spending time on Tuesday night trying to learn a little bit more, because you learn from lots of different places, and hopefully I'm giving you real life, real time stuff to help you, because this is stuff that I had to deal with all the time. And I go out and I see people and I talk to people, and I oversee a lot of other med spas and nurses, so I see all the problems, I see all the mistakes, I see all the errors, and guess what? They keep repeating over and over and over and over again. No matter how often I talk about this, I still see the same problems. So hopefully you guys are listening and it doesn't happen. So what is a touch-up? So if you treat someone for the first time and you're doing it conservatively because you understand the anatomy and you understand the frontalis being very weak. You understand that there's 4 sets of muscles pulling down and only 1 set pulling up, and you don't want ptosis of the eyelid or the brow, or you don't want any asymmetries, etc. You've done a really great assessment and you figured out how much to put in it, everywhere, and you're doing a good job with it. You still tell the patient, well, I've given you what I feel is the middle of the road, semi-conservative dose because I don't want to create these problems. But we'll see you back in 2 weeks, and if you do need more neurotoxin, we will be happy to provide that for you. But there will be a charge for that because we're just trying to be cautious. And most people are fine with that. We even put that in our consent forms. So if someone comes in, and you've done 15 units in there of glabella, and they come back and they still have a little bit of motion, and they still have some of those 11s, and they're like, gee, I was really hoping that these 11s wouldn't be there, and I gave you, I paid you for the neurotoxin. I still have these lines. Yeah, right. Remember that conversation we had about doing a conservative dose so we didn't create any problems, and that we were going to see you today 2 weeks later, and if there's if you need more, which you just need more, everything's great. You just need more. Your muscle is very strong and it's very active, so you need more neurotoxin. So we'll give you the neurotoxin and we'll charge you for that, and everything will be fine. The next time you come in, instead of giving you 15 units, we'll give you 20 or 25 or whatever is appropriate for that patient. That's not a touch-up, right? That's just a dose adjustment, as someone said here before, is a much kinder way of saying it. It is a dose adjustment. It's a learning step. It's our attempt to customize your treatment to get the dose that's right for you, because that's, your dose is going to be different than the next 4 patients I see. And it took me a little while to learn what's right for them, and it's not a cookie cutter place. We treat everyone individually and we try to get the best result for them. Remember, dose equals duration. So that's just, a dose adjustment, and the next time they come in, you do that and say, well, remember last time we underdosed you a little bit, we had to do that second treatment, so this time we're going to, try to get the right dose. We're going to increase, by 5 units or whatever's appropriate and go forward. Now, let's say you did all that and the patient comes in and, everything looks pretty good. This is frozen, but they've got, a little bit of extra motion out here, or maybe just one side has a little extra motion out there. And you think to yourself, well, was that frontalis muscle stronger? Did I not get it in the belly of the muscle? Did I go a little too lateral? Did I go too medial? Did the patient do something? Who knows what happened, right? But the patient needs a little treatment because they have a little excess motion of the lateral portion of the frontalis. They have not even quite a Spock brow, but just when they elevate, one brow goes a little higher. So, you think to yourself, well, Russo talks about this all the time, and it's not a big deal. It's easy to give a little bit more neurotoxin. So I'm going to give, 2, 2.5, 3, whatever number of units you think is appropriate, in the highest arch on that brow, and settle the brow down. You might argue that if that patient's come in and spent money for 40 or 50 or 60 units of neurotoxin, to give them 3 more and charge them for that, it's probably not that cool. It's probably not super cool. So I, consider that a touch-up. I make a little note, needed a little more on the right frontalis, check, do a better assessment next time, see if that muscle's strong or whatever. So, and you know what? That, say, free 3 units goes a long way. I mean, it's not a lot out of your pocketbook. If you're paying $6 a unit and you give them 3 of those, it's $18 and change. So, that $18 and change is going to get you a very grateful, happy patient who says, that provider stands by their work. They really wanted to get it right. They didn't even charge me for the extra, for the touch-up. Those are good things. Those are good things to have happen. Part of it is just maybe our assessment wasn't great. Part of it was maybe we did go a little deeper, a little superficial on one side. There's a million technical reasons why it wouldn't be exactly right. But next time the patient comes in and their neurotoxin is worn off, you'll be better at assessing it, and then you'll sort of, you'll learn through that, I don't want to call it a mistake, but that miscalculation, that misdosing, that's going to make you a better injector. But it only makes you a better injector. Hello, how are you, Tatiana? It's been a long time since we've spoken. It's good to see you. So that goes a long way toward your education, but you have to be open to understanding what happened and why, right? So, to me, touch-ups are situations that really aren't anyone's fault, and they happen less frequently as you get more experienced. Underdosing is not a touch-up if you're trying to be conservative with someone and you sort of explain to them that it takes a little bit of time. It takes 3 or 4 sessions to get your dose exactly right. Sometimes it's the first time, sometimes it's not. If you've ever treated a patient the very first time, had a ptosis or an asymmetry or any Spock bar or anything like that, it's hard to keep that patient. It's hard to keep them because they've probably been to other places where that didn't happen. So we know it can happen to anyone, anytime, but it's a tough way to start a relationship. So do your best. So, we've had patients where, you've given them neurotoxin and for some reason it just doesn't seem to be working very well. This is a good one for you. See who can come up with this. Good to see you as well. Let's say you have a patient that you've treated 5 to 7 times before with, let's just say Botox in this instance. And the 6th time you treat them, you use pretty much the same dose that you've established, works with them well over time. And all of a sudden, you treat them and everything's fine. You talk about their kids and the weather and their vacations and everything. Everything's good. And they call you they come in for their next visit. They say, Dr. Russo, I don't know exactly what happened last time, but, usually when you inject me, it lasts like 3.5 to 4 months. But for some reason, I noticed like at 2.5 months, certainly by 3 months, that it really wasn't there anymore. The effect wasn't there. I started noticing my emotion. Did you do something different last time? Let me just check my chart, Janie. You know what? No, I did exactly the same, number of units, same location, everything was the same. Are you sure? Yeah, Dr. Russo, look, I'm sure it's back, and it usually isn't back by now. And I know that over time, as you do neurotoxin more and more and more, the muscle starts to atrophy. You don't need as much neurotoxin. It lasts longer, but it seems like that's not working. You know what? Okay. Let's just try it again. I'll even give you a discount this time because I feel bad about what happened, but let's just do it again. We do it again. This time, she doesn't even wait for the 3-month interval. She comes in at 2.5 months and goes, look, it's gone even faster this time. I got 2 months. I noticed this was wearing off. Are you using Botox? What are you doing? Are you diluting it? Are you giving... Anybody know what's going on? Can anyone diagnose the problem? If this ever happened to anyone, this will happen at some point in your career. You have to understand what it is. I'll give you a hint. Brittany knows the answer to this because she's worked with me. Yeah. What do you mean by resistance to Botox? How do you develop resistance to Botox, Cynthia? Working. Yeah, if you work out, it does accelerate your metabolism, but not like this. It doesn't make Botox go from 4 months to 2. No, she's not working out a lot. Doing it too soon because the receptors. No. So, Cynthia, you were very close. Cynthia's on it. Let's see if she comes up with the right answer. She said, I can't remember exactly what she said, but she was saying developing a sensitivity to it. I think you used the word sensitivity. Very close. Could anyone help Cynthia out? So you've been injecting a patient with neurotoxin for 2 years, and they've been perfectly fine. They get 4 months duration. And all of a sudden, the next time they come in, said it only lasted 3, and the next time they come in, said it only lasted 2. You're using the same dose, the same product. Body's getting used to Botox. No, it's much more aggressive than that. She's not working out a lot. Antibodies. Yes, it has to do with antibodies. What are the antibodies doing? What are the antibodies doing? What are they attacking? Are the antibodies attacking the part of the molecule that the 150 kilodalton nucleus that has the long chain and the short chain that's cleaving the snare proteins? Or is it something else? I know people know this. I hope you know this stuff. So what is a Botox? I use in this case Botox because I'm going to talk about another product in a minute. But a Botox molecule is a 150 kilodalton chain, right? 150 kilodalton nucleus, a long chain and a short chain, surrounded by a sea of complexing proteins. All 4 neurotoxins, Botox, Dysport, Jeuveau, and Xeomin, have the same 150. Yes, Cynthia, I knew you'd come back to me. All of them have the same 150 kilodalton nucleus that does the dirty work, that gets inside the nerve and does the cleaving of the snare proteins. So the part of the molecule that does the work is identical in all four formulations, right? Botox, Xeomin, Jeuveau, and Dysport. What's different, as Cynthia points out, are the complexing proteins. And in this case, the patient that was getting Botox developed antibodies, because think about it. Anytime you're injecting proteins into a patient multiple times, your body can develop antibodies to those proteins. If they're not meant to be in your body, right? And the complexing proteins from neurotoxins are not. They're not found in your body. They're antigens, right? And if you have a high enough dose of those antigens, and again, it's mostly seen in not our cosmetic patients, but it's seen much more frequently on the medical side, where they're using it for spastic neuroplegia or torticollis, one of those injections where they're doing not 50 units, but 500 or 600 or 800 units. You're injecting it into big muscles. So they see this a lot more commonly. So they're developing antibodies to the complexing proteins. So as soon as you inject the product, the antibodies attack it, and it doesn't even get into the nerve. Hardly any of it does. It gets neutralized before it even gets to the nerve. So that process is real, and it happens, and you have to understand it. And other people here said change to other neurotoxin. Well, Mer's product, I'm blanking on the name now, Xeomin, is a naked neurotoxin molecule. It's just the 150 kilodalton nucleus that they all have with no proteins on it. It's the only one that doesn't have proteins. But the proteins in Botox are different than the proteins in Jeuveau, which are different than the proteins in Dysport. So you can change to any of the other neurotoxins. Often people go with Xeomin because they know there are no complexing proteins. Hey, Dime, got a nickel I can spare? That's Cassie. So it's important to know that, because if that ever happens to you, you'll be like, I remember Russo talking about that developing antibodies to the complexing proteins. It's rare. We see it maybe, once or twice a year, but when you see it, you got to know it. Otherwise, you're just going to waste your time and the patient's money chasing something that isn't going to help. So remember that. So that's kind of an interesting thing. Not a lot of people talk about it, but it is real. In fact, I talked to the scientist who actually developed Xeomin. He used to work for Allergan when they developed Botox, and he was so freaked out by this protein allergy issue, not allergy, but this protein antibody development against the proteins, that he developed Xeomin specifically with no proteins to avoid ever having that problem with the antibodies attacking the molecule. So it was kind of interesting. He was an older guy from Germany. He was a delightful guy, and he was going through all the science, and they were talking about how this happens, and the more times you give neurotoxin and proteins, the more commonly this happens. But honestly, in the aesthetic space, with our dosing being as low as it is, it doesn't happen that often, but be aware of it. So back to touch-up. So we know dose equals duration. We know the on-label dosing. So how do we avoid touch-ups, right? So we avoid touch-ups by doing the dosing close to what the on-label indications are, and we do it based upon building the patient up to the point where we know that we're going to get a good result, and trying to push the dose equals duration model, because the more neurotoxin you give them, the longer your results are going to last, and the more you're going to stand out from your peers. Secondly, tell the patients what to exist. We used to get a lot of calls from day 2 through 14 when people would be like, we're saying, it's not really working, I still have motion, or one eyebrow's higher, or this and that. 90% of that stuff takes care of itself. So explain to patients that it's not going to work right away. You're not going to see anything for a couple of days. It's going to start working on day 3 or so. And you're not going to really see the end result of this injection for 2 weeks, and then we'll see you back in 2 weeks and we can look at it together. So just explain to them what happened, because patients don't like it when something happens and they haven't been told about it and they don't understand it. Also, it's really important to do photos before you ever touch the patients, because once you start injecting them, they'll start saying things like, Dr. Russo, before you started injecting me, I never had these lines over here. And since you started giving me Botox, these lines developed. Is that possible? Not really. They were focused on these lines. They didn't see the, as soon as you change the curtains and the rug looks bad and the color of the paint looks, wrong, you have to sort of change everything. You start noticing other things. So just like anything else on the face, you start making the chin bigger, the lips look smaller, you start making the cheeks bigger, the temples look more hollow. It's all connected and related, right? So you take your photos out and say, you know what? Let's look. Oh my God! Look, those lines were actually here before. I had people say, "I never had this mole before you started injecting Botox." We know these things are crazy, but when people are hyper focused on one or two areas, they don't see the other areas. Then when those problems are solved, they start looking for other areas. So, do photographs to prove that that right brow was always a little higher, or that left eye was always a little bit more ptotic, and ideally you want to point it out before you treat them. Right? If you're really good, you look at them and go, I just want to point out some of the things. In fact, if you have a TV in your room and you can bring their face up and make it as big as the screen and say, my God, look at all those wrinkles. Look how high that right brow is relative to the left. Look at how deficient that cheek is. Oh, look at, you even got a little bit of ptosis in your left eye. Do you see that? So then they'll never blame you for anything because it's them, right? Not that you need to blame them, but you want to show them that it's pre-existing. So be sure that you do those photos. Really, really important. Also, set realistic expectations. So if a patient comes in and they're, 65 or 70 years old and they've got, really deep 11s or 111s or 1,111s, and you do your spread test and you still see the lines, you got to let them know that neurotoxin alone is not going to solve their problem. It's not going to get rid of the 11s. They have lines at rest, and those lines are deep, and it's like a crease in a piece of paper. Excuse me, if you crease it with your thumbnail, that crease never comes out. So, when you get a little older and you've been creasing your skin for 70 years, sometimes the lines are so deep that you can't do it with neurotoxin alone. So if that happens, the patient comes in, that's not a touch-up. You sort of say, hey, I told you that neurotoxin alone wouldn't do that, and you probably need to have a little filler there or some energy-based treatments or whatever, but usually it's filler. That's a very dangerous area, by the way. So part of it is setting realistic expectations. Those lines are just so deep that we're not going to get rid of all of them. We're going to soften it, we're going to smooth it, but we're not going to get rid of them, just so you understand. So if they come in and they want more and they need another treatment, well, that's not a touch-up either. That's just like an alternate treatment that has to take up space, because and they have to pay for it because they waited 70 years or whatever it was for treatment, and it's not your fault, right? Or they've got such bad sun damage and that sort of stuff. Not sitting really, yes. Also, what else can you do? Because a lot of these patients, no one needs just one thing. No one needs just neurotoxin. Even young people need skincare and protection and SPF stuff and all kinds of things, and hydrofacials and dermaglows and all that stuff. The facial assessment portion is my favorite part of the cadaver course, taught by me at Aesthetic Mentor. Thank you for all of these reasons, setting the right expectations. Yeah, thank you. I appreciate you saying that, because as you get more advanced, it really becomes the most important part of the treatment, because if you can't figure out what side is which side is fuller, which brow is higher, you're going to probably make the problem worse. So you have to really be good at your assessment and really examine the patient well before you treat them, so you can be sure you're doing the right thing. But thank you for that. And I enjoy stretching people's brains, and I enjoy seeing the growth that people have during that hour and a half, whatever we spend together. 2 hours, because you can just tell people are going to be better, and by the end of it they can do such a better assessment than they could 2 hours before. And it always amazes me at how people can grow right in front of my very eyes, and I love it. And thank you for being part of that. Never take just one cadaver course. Take at least one every year, every 2 years, because the more you know, the more you're going to learn from the courses, and the more you learn, the better injector you're going to be, the more confident and competent injector you're going to be. So agree, and I got another agree. MK agrees on that. So when you're seeing patients and they're coming in for neurotoxin and fillers, sell them skincare, sell them SPF, sell them Diamond Glow, sell them on energy-based treatments. Do other stuff to enhance and maintain your, so if you're doing a great forehead treatment, a great glabellar treatment, a crow's feet, sell them something that keeps increasing their collagen. Do some energy-based treatments. Do some radio frequency, ultrasound, laser, something around their eyes. Do some to the forehead. make your results better. Give them some HA5, some good skincare products that are going to make the skin shine. So, it makes your result better, right? It's a simple, easy thing. And it's a way of creating another revenue stream. And it's a way of, what are patients paying for? Patients are paying for outcomes. Patients are paying for good results, good outcomes, and I'm getting the high side. So you're selling outcomes and you're selling value. So the more stuff you can do to make the results better, the better you are going to be as an injector, the more happy your patient's going to be. Patients don't really mind paying for good results. They actually want to pay for good results. They hate paying for crappy results. They hate being underdosed. They hate complications. They don't like people who aren't honest with them. They like transparency. But most of all that goes away as long as they get a good result that it lasts for a while. Anyway, I got to run because I'm running over my time. But it was great talking to you this week. It's been a pleasure, and I hope you learned something. Go out there, be great, be confident, and be your best self, and learn a lot. Talk soon. See you next week. Bye, guys.